Hello, everybody. Welcome to Symmetry's webinar series. Today, we have the compliance and regulatory team to talk to us about compliance and regulatory issues. We're going to give everybody just a minute to get in the room, get their audio and their video hooked up, and we'll get started here in just a minute. As we're waiting for everybody to join us, just a couple of things of note. If you have any questions or need additional information, please don't hesitate to use the Q&A feature. As we're waiting for everybody to get set up, I just want to make sure you all know about Symmetry and who we are. We serve post-acute and behavioral health organizations across the United States. We're in all 50 states. We have clients everywhere. We can help you with any service that you may need, from outsourced services to talent solutions, to consulting, to compliance and regulatory information. We have experts in every field, so no matter what you need or what you may have questions about, we have somebody that can help you. Today, I'm really lucky to be joined by two of our survey and regulatory compliance experts, Laurie and Lynn. And I'm going to go ahead and turn the presentation over to them. I will be posting the handout in the chat here in just a minute. So if you're looking for the handout, I'll have that posted here for you in just a moment. And with that, I'm going to turn it over to Laurie and Lynn to get us started for today.
Well, hello, everyone. My name is Lynn Smith, and I'm a senior manager on the compliance and regulatory team. I'm very pleased to be presenting today's Symmetry webinar titled Survey Readiness for Home Health and Hospice, What Can Providers Do? Joining me in the presenting today's webinar is Laurie Newlun, who is also a senior manager on the compliance and regulatory team. We hope this webinar will help to answer that question. Even the most prepared operations are blindsided by unexpected interpretations and requirements. And as we know, things just seem to be continuing to change monthly. It's more important than ever for home health and hospice organizations to be ready for the survey process. In today's webinar, Laurie and I will outline the survey process and what providers can expect with upcoming surveys, and importantly, we'll discuss key strategies that agencies can utilize to implement proactive, agency-wide, ongoing survey readiness program. We welcome questions and answers during our presentation. We may be able to even answer some questions during the presentation if time will allow, and then after the presentation. If we're not able to do that during the presentation or after, we will make sure to, we have your emails, and we'll make sure to get right back to you with any answers that you might want. So what are our objectives? We want to provide an overview of the survey process, identify top survey issues impacting home health and hospice, describe survey readiness strategies for home health and hospice providers. Basically, what we're going to do today is I'm going to cover more on the home health end of things, and then Laurie will cover hospice. So we're going to basically what we're going to be looking at is how to prepare you for the survey, but basically all agencies need to be survey ready at all times. So what type of surveys? We have a state survey. That's where your state Department of Health would come and do your survey. Also, there are deemed status accreditation surveys. Now, this is when you're using an accrediting body to do your survey. And when we say deemed, what that means is that they're doing the Medicare part of the survey, but also they themselves will have standards that you have to follow. And you'll see where the different options are ACHC, CHAP, and the Joint Commission. And then there still is a CMS validation survey, where what happens is a CMS team or contractor conducts an independent survey within 60 days of the state survey to compare the results. Also, sometimes you may see a CMS validation survey that comes after an accrediting body comes and does your survey. They will actually come after them to relook at the survey, how it went, and if they feel that all the findings were validated while the survey was there. Okay, so preparing for surveys. We have, there's the different types of survey. Your initial survey where you are just starting up in the starting your agency, and there's different things that you have to look at for that, how many patients you've taken care of, discharged, and different things like that in order to be able to be ready for the initial survey. A standard survey is every 36 months at the minimum, where they review select numbers of standards. The extended survey is when a condition level deficiency is found. And what that is when that is going to require the surveyor to come, a surveyor to come back. And then a complaint survey is you may get complaints that are directed to the Department of Health, or they will send a complaint survey to the accrediting body that you've utilized for survey, and then a validation survey, which we talked about. Okay, the next slide, you can see where just a reminder of where to go as far as for hospice and home health. The Appendix M for hospice, Laurie's going to briefly go into it, but there's a lot of changes within the survey process for hospice. So please make sure, really look at Appendix M. It really outlines how the survey process has changed for hospice. Standards have not changed, the COPs have not changed, but the process itself has. And then the Appendix B for home health is there also for your reference. And again, all CMS surveys are unannounced.
Yeah, when we look at the survey process for hospice, the first thing to note is that your survey team makeup will be changing. In the past, we've typically had all nurses, but there was a change made to that last year. So I think you'll see more scrutiny over areas that you haven't seen in the past. So it's important to understand the processes that are outlined in the state operations manual. It really does a great job of outlining for you what you can expect to see, how you can expect to see things reviewed. As Lynn said, the COPs have not changed, and many surveyors who were experts in a specific area utilized many of these processes, but you didn't necessarily see them all utilize those processes. Now the goal is that you'll have consistent practices regardless of who is in, and that the process will mirror the same thing no matter who is in your organization. So it's important to look at that survey process and how it will be conducted as well. Next slide.
So preparing for surveys. This was pretty much a slide that was utilized for both home health and hospice, but actually we're just going to refer to this for home health. You have your pre-survey preparation, your entrance interview, information gathering, analysis, exit conference, statement of deficiency, plan of correction. You can do your informal dispute resolution and appeal. So you're going to see where for this is primarily more for home health, because Laurie's going to go over this. This was a big change with hospice, as far as they totally outlined and are very specific as related to the guidelines of the hospice survey process. Next slide. Next slide, Missy.
So this,
yeah, there we go.
So this slide really outlines the survey process that has been updated for the hospices. And as you'll see, they've really divided things into tasks so that it's broken down into a systematic process from the time the surveyor comes into your organization until they leave. There's really a consistency in what you will see as a part of that process. These are tasks and content changes. There used to be 6 tasks. Now there are 7 that the surveyors must follow for hospice. And I will say that sometimes these are transparent to you. They just move from one thing to the next as a transparent part of the process. So don't expect that you're going to have that announced to you that we're in this phase now. It's really just a transparent process. The guidance to the surveyors in each of these tasks is much more comprehensive. As I said, they've really outlined the processes much better so that you can understand it better and the surveyors can be consistent in the processes that they use. The sample selection of the records is now in its own task. And as we will talk about later, the sample selection for records has changed just a little bit. We'll see a review of more records than we're used to seeing in the past. The procedures and probes used by surveyors to access compliance and quality related to the interpretive guidelines will be more consistent. They're now part of the surveyor's task that's primarily in task 4, which is their information gathering phase 1 and 2, as we have outlined here. And in task 4, the overview information gathered is a systematic process to assess the hospice's compliance with the COPs. It makes sure that there's consistency and accuracy and that the surveyors gather information using a set of procedures that are common across all provider types. So you'll see duplication of those processes, regardless whether you have just a hospice. If you have hospice and home health, you'll see sort of that same process utilized for information gathering, the review process to ensure that the entrance conference and the preparation is done consistently the same. A few non-clinical documents are required in conjunction with specific COP guidelines. You know, we've always had to fill out entrance information that tells them about our census, what our staff makeup is, all those pieces, those will remain the same. And however, not all clinical documents are routinely reviewed unless the surveyors identified concerns. So we will ask for specific things related to findings and information that would indicate what's happening and how your organization is organized, especially if you have multiple sites. That's going to be very important. So you want to be sure that you have all this information available, and we'll talk about that a little bit later as well. As a reminder, you also want to be surveyed for compliance with your own agency's policies. So ensure that when you look at information, you're not only looking at what the COP says, but you're making sure that your policy aligns with the COP and your staff are familiar and know how to operationalize that information. So when we look here, we see task 1 is this pre-survey preparation process, which is enhanced with that additional external and internal resources so that we can make good determinations on the patients we will see, the clinical reviews that we will do, the home visits, all those pieces. They also will be looking at background information like your PEPR report, doing media searches, looking at your CMS hospice compare information to find out where you may be weak or areas that they should really focus on. You'll have and those things typically happen before they come on site. However, they could ask you for some of that additional information. And you'll see that when they come on site, they may also ask you for additional information like your complaint logs, your call logs, all those pieces to make determinations on who they will select for review. As a part of that entrance conference, they will review the process that will take place throughout the week and talk about this entire process. They will make a sample selection. So you want to have all that information available so that they can make that sample selection quickly and easily. Want to be sure that you define the sample selection protocol. They'll tell you how they're going to do that. They'll utilize your quality and claims-based measures and your hospice compare data. And then we talked about the information gathering phase, where that's not only the review, but the collection of data. And as they find additional information, there may be other things asked for to substantiate what's occurring during this information gathering phase. And then you have your preliminary decision making and your analysis of your findings. And finally, that exit conference, which talks about what the findings were of the surveyor. And then we see that they have the post-survey activities. If you have any plan of correction that needs to be done, any follow-up, all those kind of pieces. And they're really, these are all divided into tasks. So while this sample selection task, that's the one you see that says new next to it, was a part of what they did in the past, it's now its own task to help surveyors stay in a consistent manner about what they do and how they utilize information. Next slide.
And Missy, can you go back to slide 7? I realized I just totally went by it. I got a little mouse happy there and went right by it. So it's the one previous to that one. Yeah, there we go. And it actually fits in, I think, probably better after this one. Also, when we talk about survey process overview for both home health and hospice, they are surveyed separately, but they may have similar issues. If you're, from a surveyor perspective, if you're surveying home health and hospice, You may have some joint sessions where their QAPI may be together. Governing board is basically over both of those. Emergency management plans, things like that. You may find that those are all together. But even though the surveyor will have joint sessions for those, if there's observations in those joint sessions, what you're going to see is findings in both home health and hospice, because they actually may be the same finding, but the COPs and the tags are different. You have your G tags and your L tags. So sometimes when you have both entities as part of your organization, you may find, wow, we're being scored double for things. Well, it's going to score separately in hospice and home health. So the surveyor is going to verify compliance with all regulatory requirements to the applicable COPs. They will conduct observations and record reviews at multiple locations if you have additional locations, and deficiencies found at any location are applicable, I never say that right, to the entire home health or hospice. So another thing also you may see sometimes is if you have a DME sometimes will go under the home health arena, and that will score under your findings as well. So you may find that when you have multiple entities underneath your organization, that you have multiple observations, and they could be the same. The other thing is to remember, if you're using an accrediting body, say Joint Commission or ACHC, they have their own standards as well as CHAP. So you have to make sure that you're aware of all of those standards in addition to the COPs. So you're following all that, as well as what Laurie said in regard to your policies, procedures, all of that. A surveyor, if they're questioning something related to an observation that they have seen, if they're not sure where it falls into the standards, they will ask, what does your policy state? And you have to make sure that you're following your policy accordingly. Okay, now we're going to go to 10.
I think it's also important, Lynn, here to note that just because you have two different service lines doesn't necessarily mean that they'll be surveyed together. You could have separate surveys. So right. You need to understand that you may be asked for the same things twice, right. Sometimes. So be aware of that as well.
Exactly. Because there are some agencies that their hospice has their own QA people and home health has their own, and you end up having, separate sessions. So it can go either way.
Yeah. And I just say that related to availability. I mean, there's nothing worse for a surveyor than not to be able to get their hands on the information that they need. So you want to be sure that you're prepared for that.
Exactly. So the survey process, the overview, what are they looking at? They're looking at patient outcomes, implementation of the requirements, provision of care and services, and they're going to address COPs in the most efficient manner possible. So how do they do that? How does the surveyor do that? Well, whether it be through observation, interviews, home visits, record reviews, that can be clinical, personal records, other documentation such as policies, looking at your QAPI program, your emergency management program, infection control. And then hospice, of course, has even more to look at when you have to look at your bereavement program, volunteer program, and the IDG. So I'm going to let Laurie touch a little bit on to hospice, because there's definitely a little bit more that they have to look at in hospice. And what you're going to find now with hospice, with the increased records, now they want some additional validation from other disciplines. I know one of the accrediting bodies is using a pharmacist. A pharmacist is going in and helping with some of the surveys, and they found that they're very useful in the IPU setting. So just to kind of give you an idea that how they're going to start to introduce those other disciplines, like Laurie mentioned.
So thanks for noting that, Lynn. It is important to know that in your IPU setting, your survey makeup team, your team makeup may be different than it is in your home-based service review. So we know that they have adjusted the definition of things like counselor a little bit, and to include our spiritual care folks. So you may see people who are filling multiple roles. Now we're typically, if we have more than one reviewer come into the organization, you can anticipate that second, third, fourth person, however many you have, they will represent the other disciplines represented in the IDT. They will be from the counseling, They might be a spiritual leader. They could be a physician. They might be a pharmacist. We could see a social worker as a part of that. And that, as I said earlier, really is going to increase the focus on those areas where the nurse may not have had as much expertise in the past to review those records. So you should anticipate things that maybe you felt like were very secure, you want to take a second look at. Because you will have people who have increased ability to scrutinize that information when they come in as a part of your survey team. So in the past, we have had survey teams, like I said, made up primarily of nurses. The survey team now will stay always have at least one nurse, but if there's more than one surveyor, then we're going to see multiple disciplines as a part of that process. And for hospice, we know that we have things like volunteer services, which is considered uncompensated employees for us. So that process of looking at your whole volunteer program, and I know that we had some things that we had waivers for during the public health emergency, but with that ending, if you have surveys coming up in the latter part of this year, you can anticipate that they will once again be utilizing the full survey process for review of like volunteer services, for example, some things maybe that didn't happen in the past. Then we're going to have bereavement. We now are going to have folks who really have some specialty in that bereavement follow-up. So where a nurse may have just looked to see, did you have a plan of care? Was it executed? They may be really looking at the content as a part of your plan of care to ensure that it meets the needs of that family or representative who you're doing follow-up care on. So it's important that you look at that. We've seen increased review of IDG processes. And as a part of that, integration with what we have in the past considered billing review, which surveyors didn't typically get into, is now becoming part of that survey process as well. So anticipate that there will be new questions, new folks reviewing, new things highlighted for you, and questions asked that haven't been asked in the past. Next slide.
Okay, to go over survey activity home visits. This is going to be for home health and hospice. This is obviously a big area that surveyors will be looking at. So some of the things, your bag technique, hand hygiene. Also, it's important to make sure to let your staff know the surveyor is going to want them to wait outside of the visit so that they can discuss with them, what's the plan of care for this patient? What's the goals for the patient? That sort of thing prior to going into the home. The other thing, patient family rights and communication for home visits. The surveyor will look closely at the admission packets or admission binders to make sure that all the required paperwork is in the home. So it's very important to make sure that they know where that's at, because oftentimes a surveyor goes in and they have no idea where that packet is. So then therefore the surveyor knows that the calendar's not being kept up. This is for home health. Calendars maybe not being kept up, and things like that are actually required related to home health. The other thing, and Laurie will touch on too, that's big on home visits with hospice is the skilled nursing facilities, the assisted living facilities. If it's possible, and during COVID, it was not, it was definitely not much of an option because they were barely letting the nurses in, but they would love to do a visit in a skilled nursing facility or an assisted living. They're looking for that coordination, and communication is very important with that, because it can be extremely tricky atmosphere for hospice to be in, because you have to show that you have that communication and that everybody's on the same page. And obviously interviews, observations are the keys to the home visits. So what, just something to think about. Now this would be for home health, but probably same for hospice. What are they going to look for? What if they're going to want higher tech visits? They don't want to just go in and maybe do a little bit of diabetic teaching, not to say that isn't important, but they're going to want maybe IV therapy, wound care, as far as their visits. Also for home health, they're going to look at therapy. They're going to want to see possibly a therapy visits, and then possibly home health visits. And if they're not able to see some of these things, then they're going to obviously want to pull some records maybe that would entail some of that higher acuity type care. The other thing that some will look at the OASIS report, such as your potential avoidable events and different things like that, to select visits and records. So Laurie, if you want to kind of add some points, like for hospice, what would be something they might look at?
So I think the things that you brought up are also important for hospice. You know, high acuity care, especially wound management, is always something, regardless of the service line, we're going to be looking at. Understanding that hospice, we are responsible for, since we get the payment in a per diem every day, for everybody who works for us and provides care for that patient. So they will be looking at the services provided by other disciplines, maybe under contract, or did you have continuous home care and had contracted services that were assisting you with that? Your emergency preparedness plan, I don't think it matters whether you're home health or hospice, they're going to be looking to see what the plan is. For hospice, it's a little bit different in that we are 24/7 and have overall processes. We can't ship people off to the hospital. So we have to look at not only what we're doing on a home care team, but also what your SNF, your ALF are doing, understanding their processes. If you have an IPU, making sure you have a separate plan for that. Those pieces are all reviewed as a part of the survey process. As I will say and talk about a little bit later, you want to prepare your staff for this. You want to have done truck checks, look at their infection control processes, make them feel comfortable with this process so that when the survey is there, they are not in the, you know, this is coming out of the blue and they haven't ever experienced this type of process before. So coordinate with your staff, make sure they understand your policy, make sure they understand how to operationalize your policy. They understand what the requirement is. We know coming out of COVID, infection control is going to be still a big emphasis. It's just not going to be a separate survey like we saw it during COVID. It's going to be integrated much heavier into our survey process than we've seen it in the past. We, as Lynn was talking about, making sure paperwork is available. Part of the process for a hospice surveyor is having a conversation with the family or the caregiver, making sure they understand and have they had any issues around medications or DME being provided, or do they know how to reach the hospice? Have they had to call after hours? How have the response times been? Have they had any complaints? And that information also can be utilized to expand the process that they're utilizing while they're there, to understand the overall reaching processes you utilize and how you respond to things within your hospice. Next slide. So the hospice ads also has a medical director. We know that the medical director for a hospice can be an employee, W-2 employee, can be contracted, or could be a volunteer. But regardless of that, we're going to make sure that we can see the overall supervision of the hospice medical director as a part of the hospice process. We want to look at the aid training and competency requirements. We have had some changes for hospice in aid, especially retraining, where in the past we had to completely retrain the aides. Now we can concentrate on the areas where there's just deficiencies. So that's a little bit of a change. And we can also use a pseudo patient in a lab. So those are some changes that you're going to see as a part of the process. You want to plan for hospice volunteers and oversight, understand that with your volunteer services, I think I said this earlier, you're running a company within a company. So everything that you do for your compensated employees, unless you can validate a reason, you should be doing that same type of process for your volunteers as well. And that's HR, that's orientation, that's competency evaluation, that's scheduling, all those pieces. So you're going to see a lot more oversight of that information. You want to be sure that the assessment and the IDT process includes your volunteer processes, and they are included in that. As a part of the changes during the PHE, we had an update in the aid training, as I talked about. We no longer have to completely retrain those aides, and we can retain just in the areas where those skills are. We want to be, they're going to be looking to make sure that your training intervals and your competency assessments are done at the correct intervals. So those, every 14-day home visits are completed. They're done timely. They review the pieces out there. For hospice, the aide does not have to be there while those occur. You want to make sure that your annual training is done and your reorientation. And then if anything new is added to that aides, they're going to be looking for all those pieces. And I always say that HR files and those records are low-hanging fruit. So they're easy to make sure everything's there, but you got to stay on top of that, or that's a quick deficiency. the hospice medical director or the hospice physician. Make sure that you understand that for each provider number, you only have one hospice medical director. That is a question that gets asked many times, and sometimes, especially if you have multiple physicians covering multiple teams, the staff will think that whoever's covering their team is the medical director. Make sure they understand actually who your medical director is, and that your medical director understands what their responsibilities are for oversight of the medical piece of the program and oversight of other physicians who are part of the hospice program. Make sure that you have HR records for those physicians and that they include all the information needed for that. That's a common area where you see deficiencies. It could be things from vaccines, COVID testing, professional liability insurance, making sure that they keep their DEA and medical licenses up. So those are all pieces that you really want to look at and will be reviewed as a part of that home visit process as well. It kind of blends together with your HR review. Is the physician who wrote the medications have a valid DEA license or a nurse practitioner? So as a part of the process, you want to look at the governance and the administration of what's occurring. If you have multiple agencies or branches, you want to be sure that your organizational chart reflects the oversight of those other areas as well. And then if you have discharges and transfers between levels of care in hospice, it's important to understand that a discharge from a level of care has the same process kind of as a discharge from service that's live. You want to be sure that as a part of the Affordable Care Act, you're following those regulations that show that you coordinated care appropriately, that information was shared between those who are where the patient's moving from and where the patient's going to, and that you understand that that really is a discharge process from one level of care to another. Lynn, you want to give us some more information about home health?
Sure. Regarding home health, some of the higher observations that are seen a lot of times are in the admission folder and binder when it's reviewed on site. If you remember back in, I think it was 2018, where they added some additional requirements. One was they actually want scheduled, a calendar that the patient should have an active calendar in the home, and the different disciplines should be putting on when they are making the next visit. Surveyors will look at that. Also, the surveyor is going to make sure and look at any other written information that's provided to the patient. Is there a copy in the home? Did the family sign for anything regarding their rights? And they're going to be looking at consents. All of that needs to be in the home and show that they have gone over that. The other thing there was had to do with medical records, getting the medical records to them if they were requested within 4 days. That was waived during the waiver, and that is going to be coming back. It was waived for a 10-day period. Now it's going to be going back to the 4-day period. The other thing, and we'll discuss a little bit in the clinical record review, but to make sure that they not only do they have written information provided in the home, but they have documented somewhere in the documentation that everything was reviewed with the patient. So, and then the other thing that as a surveyor would be looking at is individualized emergency plan in the patient's home. This is a big one that is scored. It is required now for home health, and my guess is it will eventually be for hospice as well, because I think they were going to make a lot of changes to hospice, but then COVID came along, so that kind of took out everybody. So the patient needs an individualized emergency plan in the home. And it has to be very specific. You want to make sure and look at that. It has to basically tell, diagnosis. Do they require any, services? Do they require assistance to leave? Do they have oxygen, tube feedings? All of that has to be on that individualized emergency plan. Has to be in the home, and some sort of a copy has to be in the agency records. If the EMR, it doesn't have to be exactly the same, but it should have the same information in the EMR. And then again, I said with the schedule of the home visits, that's another one, the calendar that is found as an observation quite routinely. Again, she discussed the home health training competency. That has changed. A lot of that was waived. That's probably a whole nother webinar in itself. The change is coming now once PHE is completed, but that is going to actually come back into effect, where the aides are going to need to be their training and have to have their competencies annually again, like before.
I
Okay,
think
next.
it's, Lynn,
Okay.
also important to mention that regardless whether you're home health or hospice, you're still responsible for your service line requirements in Appendix E under the emergency plan.
Right. Okay, next slide. So the clinical record review, obviously this is an area where most of your observations come from. From a surveyor perspective, we do see, they do see things as far as, you know, your infection control, and some of the things aren't in the admission packet, different things like that on the home visits. But as far as care being provided, most of the time the care is exceptional. It's just not seen in the documentation piece. So it's so important. And I know staff, they have so much to do, but it's just so important that they paint the picture of the patient and what's going on with the patient. And when we talk about clinical record review as well, everything really goes around goals and outcomes. What are the goals and outcomes of the patients? What are the interventions to meet those goals? And what's the progress towards the goals? So when we talk about home health, I did mention when you look at the admission packet, but also when you're looking at the records, you know, the comprehensive assessment needs to be completed within 5 days, referral date and admission 48 hours after the referral date. And sometimes that doesn't always happen, that you see the patient 48 hours after the referral date, but what's important is to document that. The patient and family still has the right to say, I don't want the admission till Monday versus the referral came in on Friday, or maybe the patient's still in the hospital. A lot of times you get the referral way early and the patient's still in the hospital, or the patient is still in a nursing home and hasn't been discharged. Just make sure there's a paper trail of that, so that the surveyor can see, well, why did you not admit this patient within the 48 hours? The comprehensive assessment, again, that was part of the waivers, that they actually waived that as far as there was a longer length of time that it needed completed, but that will be required again as soon as the PHE is ended, which is scheduled for May. So you wanted to, I don't see many agencies that probably did that, but in case you were utilizing that waiver, you want to make sure that start doing your comprehensive assessments within the required 5 days. The other thing was the transfer discharge policy within the 4 business days of initial evaluation visit. That was waived, but it will be coming back as soon as the PHE is completed. And then another thing that I didn't mention that sometimes is seen in the admission folders, that as an observation, the different organizations, Agency on Aging, Center for Independent Living, all of that needs to be listed and reviewed with the patient and family. And then again, I mentioned that the emergency form was something that is a big scoring item, that they don't have the individualized emergency form. So what are we looking at for the clinical record review? We're looking at comprehensive assessment, timeliness and updates, the patient rights documents, plan of care development. And a lot of times the plan of cares are beautiful, but there's no updates. They just stop. So that's very important. And in order to do that, you have to set up good goals and outcomes in order to be able to update or show progress towards the goals. Another big one is coordination of care. And Laurie will mention a little bit in hospice, professional management. You have your IDG team that really is involved with hospice, but also with home health. You want to make sure that you are documenting during visits, not only progress towards goals, but communication with other disciplines, with your manager, things like that. You want to make sure that you're showing some sort of communication, whether it be, that if you're having like case conferencing, it's important still with home health to make sure to show that coordination of care. And then the clinical notes where a surveyor is going to look at, what services are being provided, are all the services that were ordered being provided, the frequency of visits. A lot of times they will count the visits to make sure that you're following their scope and frequency. And then consistency with the comprehensive assessment, the plan of care, and again, home health, hospice, age supervision, and documentation is a big piece of the clinical record review.
Yeah, many of these things for hospice and home health are the same. So I'm not going to go through them again. I will just say that if you look at the conditions of participation under hospice, it has a very clear delineation between all the requirements and the sections of those requirements, which start with, of course, that intake process. The things you want to remember specifically about the intake process is that we have had some changes to that, in that we now have an addendum requirement. Our notice of election has changed, so you can expect increased scrutiny around those two pieces of information going forward. They are now beginning to integrate some of the information from your PEPR report and your hospice compare to ensure that you're meeting those areas that weakness appears in. So you want to be sure that you've also looked at that and you have your records that are both by your IDG and your individual disciplines that support the need for ongoing services. The surveyor will be reviewing that to make those determinations. And those are things that overlap between a financial review and your survey process. You want to be sure, as Lynn said, that when you're developing a plan of care, not only are you addressing all the needs of that patient and establishing what the problem is, but you also want to talk about what are the interventions, what progress has the patient made, and you want to be sure that you're documenting that as a part of your ongoing assessment and your updates to your comprehensive assessment, which is your IDT meeting, no less frequently than every 15 days. Those are key pieces. For care coordination, if you have community-based physicians or care teams who are part of that follow-up for that patient, you want to be able to see that they've participated in this process, that they are aware of the updates, that they've had opportunities to contribute. That goes also for any bereavement services or volunteer services that are provided. And the hospice has ultimate responsibility and oversight for all that. So we establish a case manager who is responsible to ensure that all this happened. It's an interdisciplinary process where we're all contributing to that. But as a part of this survey process, they're going to be looking to ensure that everyone who should have had a visit there has a visit there. We have a reason why not. We have scope and frequency, and scope means why are you going? One thing in hospice that we frequently see is just PRN visits for generic reasons. Your scope should be specific to the reason that you're out there, and they're going to be looking at that information. That really informs your physicians and your other team members about what's going on and whether you need to change that plan of care. So that's a piece that you can see that a surveyor really will dig into to make a determination about. Of course, patient right documents, you want to be sure that those are in the home. So have your team check with the family, make sure they know where those things are and they can talk to that information and they know how to find it if they need it. Next slide.
Okay, just some quick, as far as the clinical record review, to continue the home health hospice aid documentation, just make sure that the care is consistent with the care plan, that you instruct and educate your aides that if the patient refuses any aspect of care or there's a change in condition, you need to make sure that there's a strong documentation that goes to the nurse, and and then sometimes they will look to see if the nurse responded to the aide notifying her. And it's very important. A lot will say, well, we text each other. Well, that's okay, but if it's not documented, it wasn't done. Also, supervisory visits reflect the review of the home health aid documentation. Just a quick, if the aide is not providing the care that consistent with the care plan, sometimes you're going to see two observations, because they'll score the fact that the aide didn't follow the care plan, but also that the nurse's supervisory visits are ineffective because she hadn't been following the plan of care. And just some additional information, they're looking at physician orders. Are they following physician orders? With hospice, you've got provision of drugs, treatment, services, DME, well, actually now with a lot of home care, teach back, return demonstration, and hospice volunteer bereavement assessment plan and documentation. So we're going to go on where Laurie and I could talk forever. We could probably keep talking all day to help you all get ready for survey, but I know we only have an hour. So we're going to go on to the next slide, which is documenting a plan of care. I'm sorry, Laurie.
I just did want to add one thing here. I think the rest of it's pretty self-explanatory, but when it comes to your orders and your DME or your services being provided, whether you're paying for that under the hospice care or not, even if it's unrelated, make sure you have an order covering that and it's part of your plan of care, because we are responsible for oversight of everything that's going on with that patient, whether it is part of our care plan or not, as a related piece of information to the terminal diagnosis.
Okay, next slide. Documented plan of care. This is always, a struggle for everyone, and educating staff on how best to document a plan of care. Again, what they're really looking for, what goals, identify your goals, make sure they're measurable and time framed. And the other thing is they're going to be looking for what interventions to achieve those goals, and whether it be in documentation, whether it be in your IDG meetings, they always want to see some sort of progress towards those goals. As far as obviously with home health, a lot of times your goal is to get them discharged, but there is a process prior to that that's important to document that.
So as a part of the hospice plan of care, I just want to mention here briefly that of the top 10 deficiencies over the last several years, 4 to 5 of those are typically around plan of care. And the plan of care outlines that the problems that are occurring, the interventions that we put in place to resolve those problems, and the goal is to show the resolution of the problem or what you're expecting to achieve. You want to be sure that that information is updated no less frequently than every 15 days, and it must show that there's progress toward those goals. Even if you're not making progress, you want to document to that, and every discipline needs to document to that information. Next slide.
So basically, your up-to-date care plans provide and promote communication between all members of the team. That could be for home health and hospice, because home health, we consider it a team when you may have the home health aide in there, may have therapy in there. It's still also that team approach. Also, you want to be very specific when you're listing your current interventions or orders related to wound care, infusion, catheters, feeding tubes. Anything that's different on that patient, you need an order, even if they have had a feeding tube forever and you're only washing it with soap and water. It will be cited as an observation if they're to state that there's no care related to that. Has to be very specific. What are you flushing with? How much you flushing with? Whether it be an IV, whether it be a feeding tube. And again, obviously on the plan of care, medication and the doses are very important to make sure that those are all correct. And also, just when you're on your home visit, just a side note, make sure that your staff is aware that they want to see them pull them bottles out. They want to see the bottles come out. They're checking the list against the bottles versus just going through the list or asking, did anything change? Because that's not what they're going to want to look for.
Yeah, and
Anything you want to add, Laurie?
I would just say also make sure that your orders are complete. When I was surveying many times, I would see orders that were missing, the reason they were taking the medication, the frequency, whether it was a tablet or a liquid, pieces of information, standard pieces that we should have as a part of an order. Next slide. So hospice ensures care coordination with any community-based attending no less frequently than every 15 days. That's part of our IDG process. It can also be seen when you are coordinating services. Maybe you're getting your orders from that physician, but you want to be sure that if that patient isn't changing a lot, you're not needing a lot of new orders, that you can show that you're coordinating care with that community-based attending physician. You may also develop and maintain a system of communication integration, including safety issues. You want to be sure you look at that. And care is provided in accordance with the plan of care. We talked about the plan of care and all the necessary pieces. You want to be sure that that information is being shared between all disciplines, especially if there's an after hours call in, that everybody is aware of that information, and that any information that's any services that are provided under arrangement, that you're including those folks as a part of that care coordination process. You want to ensure that you're sharing information with healthcare providers who maybe in the community are furnishing services as well, if it's particular to what they may have oversight of. For hospice, your IDG meetings, you want to be sure those happen as they're required and scheduled to happen, and that your documentation reflects everyone's participation and what the updates are to that. You want to ensure that all members of the patient's home health and hospice team have access to the patient's current plan of care. The family needs to know that they have a right to participate in the development and the updates of those plan of care, and they have a right to not want something that's a part of that plan of care. So you should have documentation that shows that you're reviewing this with them and that they're aware of that process. That may be part of that interview process when you're in the home to ensure that the family is aware of that. And you want to ensure that that coordination and communication is documented with each visit by all disciplines and that you're coordinating services. Lynn?
Okay. The next slide, documentation review. This is just a review of things that they're going to probably, a surveyor would look at. Review of the QAPI program, routine monitoring of follow-up related to complaints, infections, and occurrences. At this point too, also the surveyor still may look at your COVID, what happened during COVID and how did you react to the pandemic, and change your policies and different things related to that. Review your emergency plan, home health. They're going to want OASIS data, the IQUEST reports, CASPER reports, HCAPS, and then hospice. You've got your HIS data, whatever you guys call it. Your satisfaction reports again, volunteer program and bereavement program are different ones also that they're going to want to see.
Next slide.
Personnel review file. You're going to see where the main thing to keep in mind that when you're looking at personnel files, ask the surveyor up front, do they have a certain template they use for personnel files? Sometimes they'll give you a template and your HR person can actually flag the different things that they're looking for. It kind of gives you also the heads up of exactly what they're looking for and give them time to prep. They're going to want to look at anybody that they've went out on visits with. And then also maybe administrator, clinical manager. If they didn't have an aide visit, they'll look at the aides, social worker, therapies, all of that. And then of course with hospice, Laurie, if you want to add, there's additional things you're going to look for in hospice as far as for your personnel files.
Yeah, and we've talked about the medical director and hospice physicians and the nurse practitioner. You want to make sure that they all have appropriate licensure and all the pieces that are required in any HR file, which are maybe state specific or federal specific. Because we're hospice, we get paid on a per diem. So if we have other outside providers like PT/OT speech, we still have responsibility to ensure that they meet requirements. So you want to have a process in place that you have availability to access that information. You reviewed it, you're sure that's in place. If you're having any contracted nursing services for aides or any of those, you also want to make that part of your agreement and do some review of that process because your surveyor may ask for that information. If you're in a rural area and you've used a waiver, make sure that you have evidence that you really could not fill that role. It's not as simple as just saying, we can't find anyone. You should be able to provide evidence that you attempted to fill that role, that your salaries are appropriate to the scale and range, and everything you've done to do that before a waiver was implemented. And then you want to ensure that your hospice social workers meet the state requirements. They vary greatly from state to state, and that the services provided under the scope of practice for all disciplines are appropriate to what is applicable in that state or under the federal requirements. Next slide.
This slide is just kind of for your reference. These are the different things that we kind of came up with that possibly, or most of the time, the surveyors will look for. So you can kind of read that and look at that. But also, you know, again, ask if they have a template, because sometimes they'll give you that, what they're going to be looking for, because it makes it easier for them if things are already flagged and prepared. And usually they will give you the list of your personnel files the day before that they're going to review the personnel files. Next slide.
So let me say just something really quick about that slide. Aides are always a big focus, making sure your aides have their in-service hours and they are still qualified to be providing services. The other thing is I found on a lot of mock surveys is that people have segregated their COVID vaccinations or their waivers for COVID vaccinations, and they're not part of the regular record. They don't necessarily have to be, but you need to be sure that your surveyor has access to that information. So make sure you've discussed that if you're keeping them in a corporate HR record or somewhere else, so that when the surveyor comes on site, they will have access to all the information they need. Okay. Next.
Okay. This is just going over what the actual standard versus condition level deficiencies during your survey process. Standard level deficiencies, obviously that's what you like to see. because that's not going to require the surveyor to come back to visit you. And it's going to require that once you have your plan of correction in place, then and work on that, that's all that's going to be needed. A condition level deficiency is when there's non-compliance in not just a single standard, but several standards, and that could actually cause possibly a risk to a patient, more of a risk. Then that's going to require the surveyor to come back. And when they come back, what they do is they're going to look at the condition level deficiencies and clear them usually within 45 days. But I always tell agencies I would be ready in 30, just in case, and just be able to clear the condition level deficiencies during that time. So the next couple slides, just for review, are just the top deficiencies and I know Laurie's mentioned some, so have I. You're going to get the top deficiencies for home health, and you can see for both home health and for hospice plan of care. It's the big score, and a lot of times the plan of care is the big one is outcomes, measurable outcomes and goals, because if those aren't set up well and based on the comprehensive assessment, then there are issues with the rest of the documentation.
And I will just add quickly on the conditions and standard level deficiencies, it isn't always as clear cut in hospice as it is in home health. You can have one instance of where a patient could have received harm, and you may still have a condition level citation. So be aware that there's some little different criteria and standards between the two.
Okay, we're running out of time. I'm sure you totally enjoyed talking with us, but listening to us, I guess. But I'm going to just kind of briefly go through the next few slides. The additional regulatory considerations, this is just going through to what to look, your state licensure, your accreditation requirements. Again, what I said with the standards, they have their own standards. So you want to make sure that you're know those as well and you're following those. Your governing body administration is very important related to the survey process, your QAPI program, your policies, procedures, and just I did highlight the CMS website, talks about the COVID waiver, that it's, that the PHE is ending. They have a couple beautiful sheets that totally goes over each waiver, that and then when it's the waiver's ending, and some actually are still staying put. So it's a great site to go that you can find out that information. Now, if you go all the way down to survey readiness strategies, really this is something that you can go through on your own. The key that what we always say too is being a former surveyor. If you walk into the agency, they have a binder, they have everything in that binder that's requested. You can get the information from your accrediting body or from the state. They have a list of different things that they want for the survey prior to the surveyor even getting there. So have those prepared, as well as just one other thing to think about that's very important. As soon as you know that that the surveyor is coming, get working on printing up the different documentation, the census, the active census, the discharge census, different things, your unduplicated census number. Have that ready to go before he or she even gets there. And the other thing is EMR access. There is nothing worse than sitting there for 2 hours waiting to get access to the records. So you want to make sure that that's top priority. And you'll see the different things that what we talk about, things to get ready, but it's all centered around, we always have to have those handy dandy binders. I don't think we're ever going to get rid of them, but you can see where that's all this is survey binder and preparation documents. The more you have on ready for that surveyor, the easier the survey process is going to be. And like Laurie said, and they may ask for hospice stuff, and they're going to ask for home health things. They're going to ask for things together if you have an agency with multiple entities. But the more prepared you are upfront and ready to go, the better it's going to be, the less painful it's going to be, I guess is probably the best word to say.
So a couple things we didn't mention specifically that I just want to bring out really quick, Lynn, is make sure you have access to your governing body minutes.
Right.
Sometimes those are kept in a different location and they will want to see that information. The other thing on the hospice side is be aware that you have specific education requirements for skilled nursing facilities, either for you to provide or evidence that someone else has provided those to a skilled nursing facility. Those are common things that are missed. So be familiar with what those are and have some evidence that it's been provided.
Okay, and just the final reminders, basically the one thing, ensure all your staff, your managers understand their role in survey readiness and response. A good thing is conduct a mock survey. We do survey readiness as part of our organization. We go out and we do mock surveys as part of Symmetry and kind of help you be able to get a little more comfortable with the survey process. So that's an option. You can always call us, but you can do it within yourself, within the agency itself.
Yeah.
And just remember the focus is primarily on patient care. So you want to look at a strong, look at your record review process, staff education, supervisory visits, all of that are key areas to the survey process. But the key is survey readiness is an ongoing agency-wide effort, and it's every day. You should be survey ready every day. I did see there's a few questions, Missy. I'm sure people probably have things to do. I can get back to them, via their email, if that would work better.
Absolutely. We'll address all these questions in email. I'll have Lynn or Laurie will respond back to you depending on your question. If you have additional questions or are looking for more information, I put up Laurie and Lynn's email information. Feel free to reach out to them at any point in time or go to our website, symmetryhc.com, and we'd be more than happy to help you. A copy of the recording and the handout will be sent out to everybody. So thank you again for joining us. Lynn and Laurie, thank you for sharing such great information. I hope you all have a wonderful day.
Thank you.
Thank you.